very rapid change in diabetes. Be very careful if other people are managing diabetes early on. The hospitals come around and say, well, we're going to restart your glyburide and all your metformin, and we're going to put you on your Lantus, and then we'll do sliding scale. That patient's going to have a blood sugar of 40. Okay, with the gastric bypass especially, the hormonal changes with the pancreas and the liver are very early, within the first 72 hours. So we basically go usually to metformin and sliding scale regular insulin until we're 2 or 3 days out. Even if somebody's been on 105 units a day of insulin, I pretty much don't put them back on any long-acting insulin until they're a couple of weeks out. Then if, you know, then we've got at least a better idea of what their daily rate is going to be. And as they lose weight, they're going to need even less. So there's a synergistic effect. In fact, there's a great study that shows that if you take somebody, two people with similar diabetes and similar weight, and one loses weight without surgery and one loses weight with gastric bypass, at the new lower weight, the patient with a gastric bypass has better glucose control than the patient who lost it without surgery, because the additive effect of that bypass, of the mechanical change leading to hormonal changes.
So just one other thing,
Yeah.
is the hunger thing at the top of the stomach then?
Well, there's a lot of stuff involved in hunger. Ghrelin is made in the upper stomach, and when the sleeve removes that part of the stomach, we think that changes how ghrelin. But there's a lot of hormones that talk to the brain to say we're short of this and we're short of that. But definitely, when food seems to sit at the top of the stomach, that really helps with the satiety signal. So there are stretch receptors, there are chemical receptors. That's worthy of a couple of hours of talk that's above my head. But it's very cool stuff, and we're learning more and more every year on that. All right. Liver labs, you'll see this once a year. We don't usually check liver labs. We compress that liver out of the way to get to the stomach for an hour or two. When you compress the liver, the next day the labs bump. It doesn't mean they're having liver failure. So I got stories for every one of these lines, but I just have to leave it at that. But just be careful if somebody happens to come through and check a CMP and then freaks out. They must have gallbladder problems. No, I was mashing on the liver. So, especially the first couple of days. It should be down within a week, but all right. So very late issues. Small bowel obstruction is very different for gastric bypass than it is for any other operation, because bowel gets twisted and dies early after gastric bypass. This is not admit, put an NG tube and watch. First of all, put an NG tube down in that little bitty stomach, you can perforate that small bowel. Never, ever put an NG tube in a patient with a gastric bypass. I don't care if they're 50 years post-op, okay? And try to not let any doc do. I'll do it. No, don't let them do it. Even I don't want to put them in blind. If I had to put a tube in, I would put it in with endoscopic guidance. There's really no role for decompression of that little stomach. If you have a bowel obstruction, something is kinked or blocking, and we need to go in surgically and release it. A paper out a month or two ago showed gastric bypass bowel obstructions, more than 60 to 70% of them go to the ER during that hospitalization. Your average North American bowel obstruction, less than 30%, 35% go to the OR on average, you know, after hysterectomy or appendix or whatever. So it's a different deal. It is also a different deal because bowel can get twisted in an internal hernia and die much quicker than your average bowel obstruction. So we don't watch for 2 or 3 days. If I admit somebody with a bowel obstruction and they're really, truly obstructed, I mean vomiting, retching, and we see distended loops, we're going to go to surgery that day. If I don't see distended loops and their pain is a 3 or a 4 and it's just intermittent vomiting, I might watch him wait, but I'll tell you my inclination is, tell me why I shouldn't put 3 5mm ports in you and have a look around. Because the downside is so horrible, and you'll hear of people who've lost all their bowel, or 3/4 of their bowel because it got herniated through one of the defects. The risk is too high. The operation is not that hard. So when you see bowel obstructions admitted, they may not be admitted to me, you know what I mean? They may be admitted to the rheumatology service, you know what I mean? Or something happens while somebody's in for some other reason. Don't be afraid to call me. During pregnancy, things get pushed around in there, and it can occasionally happen, and nobody wants to take a pregnant woman to surgery, but even less do you want a pregnant woman to lose half her gut. Okay, so don't be afraid to yell. 1 or 2 other quick things on care, and then we'll wrap up. Wernicke's encephalopathy is a weird thing with low vitamin. I think it's B1 or it might be B6. It's thiamine, I think. If you're chronically low and you give somebody glucose, their body can't handle it, and they can end up with permanent neurologic damage, permanent brain or peripheral neuropathy. They need a banana bag the minute they hit the ER. We'll try to get the ER protocol set up for that, but if they come up here, you know somebody has a bypass and they're getting D5 in their IV fluids, get a banana bag. One multivitamin dose is supposedly enough to, to prevent the permanent neurologic damage.
And I'm sorry, it's because they're low on
one of the B vitamins.
One of the
yeah,
B vitamins.
I should have done more research.
Well,
Sorry.
thiamine, yeah.
Is it
It's
thiamine?
thiamine, because
Okay.
that's the
Thiamine,
word used,
so
the
yeah.
alcoholic.
It's the same as the alcoholics
Yeah,
kit.
bypass.
Right.
And it's thiamine.
But I always forget if thiamin's B1 or 6. Anyhow, I
I
shouldn't
didn't
confess
look
my
it up,
stupidity.
And that's what's in the banana.
Yeah, exactly. So just think of that early. These folks are at risk. It's not probably 1 in 1,000 patients, but permanent neurologic damage is worth easily avoiding. It's out there definitely in the malpractice literature. There's an emergency poster that the American Society for Metabolic and Bariatric Surgery puts out. I'm going to get the hospital to get one for the ER, but I'd like, if you guys are going to be the primary floor, to get the ER poster here too, because you guys will be receiving patients from the ER, and I'd like for you to know what I want them to know, and trying to talk to 20 different ER docs and get them up to speed. You're lucky if you catch 2 or 3 per in-service, right? So again, team medicine. You guys knowing as much as you can possibly know is good for all of us. Liquid diet preoperatively we do, just so you know, to shrink that liver. Fatty liver shrinks pretty quickly actually on a liquid diet. If they have bad kidneys, it can give them high potassium. Be aware of that. Also our Toradol that we give post-op, we'll try not to do it in people who have bad kidneys, but occasionally I'll miss, or I'll forget that somebody has borderline kidney function, or age related. So Toradol, sometimes you may need to call me and say, are you sure you want this patient to have Toradol? I'm happy to scratch it if it's, we don't want to risk kidneys. Atrial fibrillation can be tricky managing tachycardia. Sometimes we just muddle through on that, but if I've had one patient with paraplegia who had autonomic dysreflexia and he was tachy first night post-op, and I just took him back to the OR. It's like, why not? If he has a leak, so we've got to just work together on that stuff. It's not all easy. Social stressors, social dysfunction. A lot of people do have histories of abuse in their family. It may not always be the person in the family with a weight problem, but there are, sexual and physical and emotional abuse issues in all sorts of families. Sometimes that can come out at the time of surgery when the family's all together, and now they're all stressed because, somebody just had this elective operation. Just be aware of that. I haven't seen anything, I've never seen a fight or anything, but it's a time of high emotional drama. It's not very uncommon for me once every month or two to go into a room first day post-op and have, usually it's a young woman, burst into tears. It's as big a change as she's had in her life, ever, if she's never been married. But it's about like that, you wake up the day after getting married and you're like, wow, my life has changed. I'm happy, but it is, my life is, or having a baby, I don't have kids, but that's that emotional overwhelming. So you may see people have, a burst of, wow, I'm here. I've been working for this for years. I've been thinking about it for years, and now here I am. You can also occasionally see some weird comments. People like to talk, we were talking about the sensitivity part. There's sort of precondition that people may think they're getting the easy way out, or they're worried what you guys think about them, and they may occasionally say something goofy like, "Oh, I'm just here for the drive-through surgery." They don't usually mean it. I mean, sometimes they're testing you. Don't overreact. Occasionally, I have had some people. There are a lot of women out there, and I tell you guys, whose husbands are not that supportive of anything in their life, right? They don't want any change. They don't want them to get their hair cut shorter. They don't want this or that, And I had occasionally somebody tell her husband that, well, I'm just going in for a little procedure. I said, you're not having a hysteroscopy. This is not a pap smear. This is an operation. Your husband may be unsupportive, but you owe him a full story. But you may occasionally get in the middle of that, or somebody comes back in who had surgery 20 years ago and never told husband number 2 that they had this. Just be sensitive to that. We have to follow HIPAA. We have to follow the patient's, what they ask. But let me know before I blunder into the middle of that too. Occasionally that stuff can happen. Advocacy. You guys are advocates. You're seen as people who will validate whether this is responsible. Family will take you aside and say, are they crazy doing this? Why'd she do this? And You know, when you're able to talk knowledgeably about relative risks and benefits and the tool and the journey and the medical problems, it means a lot to patients' families, or to somebody who's in here for something else thinking about doing it. For you to validate and say, oh yeah, you know, we're the floor. People come through here and we see them do well. You also see them come back for gallbladders as well and stuff like that, which happens when you lose weight. So advocacy on that side, advocacy also through Obesity Action Coalition and through the Nurses Union. Peace Health, unfortunately, I hate saying it on the web or on tape, Peace Health does not follow the evidence. They are not even up to the 1991 standards in terms of coverage. It's still 45 with 2 comorbidities, right?
I think so.
Yeah.
My insurance was through husband.
Oh, okay. So, but
they didn't cover it.
we really need the nurses at this hospital ultimately to take the lead, not to change the nursing contract, but to change the way Peace Health administers its employee benefit and say we are going to follow the data. The unfortunate truth is, if you're an employee in this hospital and you have a BMI of 40, you have better coverage if you're disabled on Medicare than being a working, you know,
So the
healthcare professional.
insurance doesn't cover these procedures?
40, BMI 45, and you have to have had it for 5 years. If you dipped below for a little while, they won't cover you. Now, I have nothing against the WIN program or the programs that they try to do to help people get ready. I think that's fine. It's a little bit of a penalty lap. Most people have already done their homework and tried to lose weight before. There's very few people who make it to 30 without having been on diets or tried to work. But it's okay if they want to make sure that people are, but we're not following the evidence with our. So I'm working on that. That's part of my advocacy is statewide as the Access to Care representative for ASMBS, is making sure that plans and employers follow evidence the same way they do with any other
They
disease.
don't make people that need joint replacements wait. Well, lose some weight and we'll come back and redo it in 5 years.
And if you smoke and get a lung cancer,
Yeah.
they may gripe at you for smoking, but they're going to take care of the lung cancer. And that's
And they'll still
and I'm not
pay for
arguing
you if
against
you
it.
continue to smoke.
Right. You bet. You bet. It's
So
judgment
how much
free.
is it? So if you have a lower BMI and you just want it, you don't pay out of pocket, how much does it cost?
It's somewhere between. We're looking to try to do sleeves at the surgery center for about $12,000.
Come talk to me if
Yeah.
you want to. I'll help you with.
12 to 20,000 probably. I'm hoping to do the
Oh, I
imbrications for under 10.
Mm-hmm.
Again, we're still early on that. But then there's other costs as well other than just the operation. Seeing the dietitian, seeing the psychologist adds a few $100 here and there.
So we're going to see pretty good, high BMI patients, inpatient.
You will
care,
be
probably.
surprised. Administrators always think, oh, we're going to have to use the lifts now. I've had 2 people out of 850 people use the lifts, and 1 was paraplegic. The lifts are not there for surgical patients. Need to walk. They need to get up out of bed. In fact, I even stopped using those stupid big beds that roll over your, you know what I mean? They don't move. The patients don't like them. If they're more comfortable in them, that's fine. I got nothing against the big beds, but our regular beds hold people up to about 420 pounds most of the time perfectly well. They get in and out of them well, and most people who are over 500 pounds, we're going to get them to lose down to about 450 anyhow. Most people who are 600 pounds,
A lot of the imaging equipment and stuff at the
Right.
hospital only goes to 5.
yeah,
anyway,
our program
so.
in Duluth had a 450-pound weight limit, and we did a couple
The CAT
people a little over
scanner,
that.
The MRI,
But
the cath tables are all
you see somebody-
500.
You see somebody who's 600 pounds, they're carrying 75 pounds of water usually. Just managing their heart failure will get them down 50 or 60 pounds, and then doing even 6 months of medical weight management, if they're even halfway doing anything, they'll lose another 50 or 60 pounds. And they get, 450 is not bad. And we have hip patients, or we have, hysterectomy patients that weigh that. So,
So we have a lot of.
yeah. So these are not necessarily going to be the heaviest people in the hospital. And these folks usually are tuned up. They're at their healthiest because they have been worked up. It's an elective operation. If they get a bronchitis, we put it off for a couple of weeks. They get a DVT, we put it off for a few months. So, not to say they can't have problems, but they're not. Most of the people who come up here from the ER are sick. Most of my patients are actually going to be rolling, walking into that outpatient admitting well. One of our goals is to get them walking actually even before surgery for a month, 10 to 15 minutes. That's another thing in addition to get them just fit.
Probably going to talk to you. I was going to say, maybe we can put a little extra, become an extra.